Now, it's our honor and privilege to go on to the next session where we invite the Professor of Surgery, Professor Dr. Nirjhar Bhattacharjee. He will be sharing with us the experience of varicose vein surgery in a government hospital in Kolkata. Nirjhar is senior to me, but I had known him, well, nearly 30 years. We are from the same alma mater. And he's probably the only professor of general surgery in Kolkata who has an active interest in vascular surgery.
Let me come to the topic. In the government medical colleges and other hospitals, our experience in the district hospital, Imam Mara Sadar Hospital, as well as medical college, NRS, Bankura Samral Medical College, etc. See these varicose vein patients. If we divide the patients in three groups, it will be better. One and most important group is that, as said by Krishendu sir, Jayanto sir, varicose vein, not only varicose vein with features of chronic venous insufficiency and the recurrence with the complication. That is a major group. Today I will give a little bit stress on this group. Another group, though it is not that small, usually male patients, varicose vein, but there is no features of neither clinical presentation of chronic venous insufficiency. Here we should remember that sometimes my team members used to misassess that it starts from the ankle flare. So that is important, not from the pigmentation. If there is any doubt or not, for this both the groups of the patients, we, at least after clinical examination, it's a protocol to sit the patient for USG assessment of the perforators, function of the perforators. And the last group, small one, young patients usually, male, female, both, they come when they appear in the examination, there's a recruitment examination in the army or paramilitary force or police, etc., and being rejected by them, and with advice to attend the government hospital for their treatment. So I will not concentrate on that last group, minority there, and nothing difficult. Most of them, they're all, majority of them may have some spider angiomas, which needs nowadays, everyone knows that sclerotherapy is important, a dilute sclerotherapy usually, it's better. So I will concentrate within time a little bit on the difficult part that we try to manage in our inadequate setup. As a margin of our other, in the general surgery department, the margin task. So we are busy with other tasks also in the general surgery department, and the margin task is to handle with this venous patients, patient with a venous problem like varicose vein. Now see, everything has been beautifully, the major part has been given detail, including the photographs by Dr. Mukherjee, Krishendu, and Dr. Daj. So here I want to just add 1 or 2 points. What we do routinely, we have practiced and our unit is doing, and it is percolated throughout the colleges. What is that? Initially we used to, even myself, say long back, 2000, I was in the unit of Sir Professor Sukumar Maitri also at that time also. Varicose vein, only inspection, then go for ultrasonography. Proper clinical examination we were reluctant to do. But we have made a routine, not only what Dr. Krishendu has mentioned, peripheral pulse estimation, but also we ask everyone to look under the lower part of the abdomen, whether there is any varicosities or not. Second, if the patient is male, to assess whether there is any varicocele or not, at least clinically. Third, both the things, history is important. Fresh bleeding per rectum, yes or no. If there is, go for a speculum examination of the anus, as well as whether there is a history of hematemesis melena in the recent past. That we have incorporated in our history taking part, important one. At the same time, it is very important to assess the age, because you know age, atherosclerosis, diabetes, what he has highlighted already, and other factors like smoking, particularly BD smoking, BD. So that is dangerous, you know. We get a lot of patients with a BD smoker, who are BD smoker. Cigarette smoking, I think, in my experience, I don't have the data with me, but bidi smokers are very dangerous for arterial problems. Why it is important? Because everything has been explained. Not only the surgery, there is a major part before the surgery, even after the surgery, which we folded as conservative management. And that management includes application of some sorts of compression garment, class 2, class 3, gradual compression stockings, or substitute of that. Here lies the problem. If we don't assess the arterial pulses, even when we are going for ultrasound assessment, if there is any doubt, if you don't go for the arterial flow assessment, whether Doppler study, and now you apply the compression garment, one case I have seen where it was a blunder, but we could identify that case, I will present that. And one important photograph I have noted by the Dr. Krishnan was shown you, ulcer in the foot, and that was the ischemic ulcer. See, venous ulcer usually where it is occurs, in the rare occasion, except in rare occasion, it is above the ankle, lower third of the leg. Medial side is the side which is common. But here, the foot, distal part of the foot, ischemic ulcer. This is the thing I want to add with the clinical examination. Another thing is that for the undergraduate and the postgraduate, in the private setup, the clinical examination and the explanation of that, the hemodynamics is not that important, or I don't know whatever, I don't have any experience. But in the college, the study of this and knowledge of this with the students is very, very important, particularly when there is a complication, like ulceration. Among the complications, so we'll come later on, among the complications, in the teaching institution, we are always alert about, I think everyone is that, whether the complication which is known as the DVT, whether there is a DVT, deep vein thrombosis or not. I will not go in detail of that. All of you know that the next problem which comes, that is ulceration, non-healing ulcer. That is another problem. There are, say, 12 problems as a complication of the varicose vein untreated with the chronic venous insufficiency commonly happens. I'm not going to the list. In the interactive section, if you ask me, any one of the junior aspirant surgeons, I will give that detail of that. Okay, let's just skip to the other point. Now, regarding the management, in the government hospital, what you do? Rightly, Professor Mukherjee has pointed it out. Initially we used to do that, we used to prescribe either crepe bandage or a compression stocking as a conservative management. That was very common. I'm talking about those patients who has got no arterial insufficiency, for them only. So what happens practically, that has also been highlighted. If you give that suggestion to the patient in this humid, temperate climate, and the patient will follow for 2 or 3 months maximum, and they will leave it. And then the patient will come with the complication which is gradually one after another coming out. So from the 2013-14, we have adopted another thing in our unit. Naturally, many of us now in the teaching institution, they are also accepted this method. What we do, we just ask the patient, it's a time-honored thing, we ask the patient to put 3 means 21 to 22 centimeter, gradually, first 1, first 2, first 3, brick, which is commonly available, under the foot end of the bed to elevate the foot end. Not a pillow below, because while the patient is sleeping, the whole pressure of the pillow will in this curve, and the artery will be further compressed, the posterior artery. So I think it is not recommended, we think rather it is not recommended. It is better to elevate the foot end of the patient. Now how much you will live? That's a question, practical problem. What we have seen, patient tolerates well with the 3 and 3, that is 21 to 22 centimeter lift on the foot end. They feel comfortable, of course, gradually. After that, the patient doesn't feel comfortable. So that much, though you know, if you think about the elevation of the leg, what is the idea? We want to bring back the congested blood into the abdomen, isn't it? So you have to go beyond 45 degrees, because at the 45 degree, G neutralizes. So if you lift a little bit more, you are taking the gravitation, which will drain fast. So normally in the clinical examination, what do? We try to lift the leg, as because we're in hurry, for 60-degree round, always above the 45-degree. But if you ask your patient to sleep in the 45-degree elevation of the foot, it will not be acceptable for anyone. Anyhow, so this is thing we add. But in the daytime, interestingly, we are getting encouraging result. We ask those patients to lie down flat, whenever space is available, maybe in the floor, and lift your leg as far as practicable on the wall, on the furniture, whatever, only for 5 minutes, so that the congested blood come back to the abdomen, and while the patient will stand, fresh blood will go, and it will again, the congestion dropping will go on. But 1 to 1.5 hours. That idea came from our brain from where? From the tourniquet time. So if you apply a tourniquet for the lower extremity, we after 1.5 hours, we refresh it. So up to that much, the tissue may tolerate all this, this oxygenation, nutritional, etc., and going into the detail of that. So that we are practicing first in our unit. Then now it is everyone do, many of them, we see the prescriptions, and it is very much encouraging. You also try it, and we don't have a total data bank, though there are few publications. I have seen it. But we can work on that, which is, I think, very, very, very important as a part of the conservative management in our scenario, in our state, in our country. Next. When we are talking about this conservative management and the drugs, see, there are so many drugs that we have. Yes, already Dr. Das and Dr. Mukherjee told you. Pentoxifylline. Nowadays it is not available in the market properly. This Dablon is available. Calcium dobicelate, that's also a drug. But one thing it is not clear to us. We can make our experience cleared by the dedicated team like them who has how many days, how long we will give it in the conservative part. So I think in the conservative management, not only for that positioning that I have told you, it is important that we can add a little bit whenever necessary medicine. But there we don't have any, in the teaching institution, proper experience and data. You see, in the teaching institution, in our all experience, it is because of our system failure. We don't have a good data bank. All the data what are taken, that's not acceptable, I think. So that's a deficiency among many we have. Anyhow, now let's go into the next step. I'm talking about those varicose veins, 4 millimeter or more than that, palpable, along with dilated, tortuous, elongated, by definition, old definition, and with some sort of chronic venous insufficiency. Here, first thing what we do, if the patient has got, with the ultrasound evidence, we go for ultrasound only, the Doppler study. If an arterial system is okay, deep vein is okay, then what we do, we just go on Tenbach offers. And there is a flux ligation of the saphenofemoral junction. That we do routinely. Sometimes we stop there and start other mode of treatment. Sometimes we add something like shearing of the vein, that is stripping of the vein. Stripping of the vein is not possible apart from a good, long, great saphenous vein, and with a healthy skin where the vein can be visible. Stripping of the vein is always not possible. Why? Entire vein? Because you can understand, if the patient has got dermatofibroliposclerosis, it's very difficult to negotiate at the knee end. So this sort of things may happen. So that is also partially successful, maybe. And short saphenous stripping, ooze stripper, where will give? In the belly and lavsy. So we have tried umbrella stick there, but still the result is not that encouraging that I can proudly tell you that there is a data and it's a good procedure. No. Again, the problem is with the stray varicosities. You don't know where is so many perforators, we don't know. So these are all problem with this classical, with the Tenenbach procedure, the flux ligation of the saphenofemoral junction, the stripping of the great saphenous. Still we try it. Whenever possible, we try. Sometimes we combine with clocket and dot, sharing of the, with the multiple initials, we try to share it out. Now see, with this old spectra of the medical colleges that all of us, the senior person, experienced in our college life, nowadays it is getting better options we are getting with the research and development. But that is not available, but we have to fight for that. So one day we have started to do the other procedures. We have started, that is the sclerotherapy. See, it is an old thing. So with the hypertonic saline, with the 25% dextrose, even the soap, ethylenobine oleate, that's a soap, alkali. This sort of things we have learned from, not in the varicose vein, but the other. Publications also coming for that, but one fix was there. How will give it? The European publication, even with the foam which was coming, they were doing the ultrasound guidance. I'm wrong or right? See, they are putting the needle, ultrasound guidance. When they are pushing the foam or the sclerosant, they are guiding it so that it doesn't enter into the deep vein. That is very great serious problem may post-operative arise, isn't it? But where will get the ultrasound? Who will give us the ultrasound? The government setup in the OT. So initially we struggled. Finally we started with the plain sodium tetradosyl cyclate, small injections, getting success. Then the question comes, it can't cover a lot of the veins together because you know the diameter of the vein is larger. If you consider 10 centimeter of a length of a vein which is 5 millimeter diameter, it contains about 7.9 to 8 millimeter of blood. So to cover the 10 centimeter, you have to give more or less 2 ample, 2 ml, 2 ml of satrol, that is a sodium tetradosyl sulfate. Polydocanol that we have tried, it is efficient, but less than sodium tetradosyl. See, what is the basic principle of that? We want a aseptic inflammation of the intima of the vein. Am I right or not? Aseptic inflammation of the intima of the vein. Now how we can achieve it? We can do it with a chemical thing. We can do with any sort of injury, maybe chemical injury or maybe thermal injury. I'm not going into the glue and other things. It has developed many miles. Options are there, but I'm restricted myself into this only, which can be done in government hospital. Which can be done in government hospital only, in our scenario in West Bengal, till date. So these are two methods, what we can concentrate. So now this injury, aseptic inflammation of the intima of the vein, followed by pressure bandage, that is you are putting one of the vein, wall of the vein with the other wall for say 14 days, may 21 days. Why 21 days? 21 days means 21% of the tensile strength of your fibrosis will develop. That's why 21. ये song हम लोग करते रहते हैं 21. So anyhow, we need not to wait for the 21 as the pressure gradient is low in the venous system. So at least 14 days, if you do it there like that, there will be synecdoche of the vein. So it will be clogged, the simple thing. But the problem is that you cannot cover with a raw injection of sodium tetradosyl, which is available in the market in the name of cetrol or the polydocanol. So you have to go multiple sessions and sitting with all risk. Without ultrasound guidance, there is no legal safety also. So we tried, took the help from the Jadavpur University. Grateful, I will mention the name, who helped us a lot. So the Dean of A50, Professor Manoj Mitra, who given us the opportunity without any protocol, without any deposition of money over there, but we didn't have any document. They sent me us to Professor Vishwanath Mukherjee, the pharmacy department, and he assessed the viscosity, the specificity, etc. And we got a report and saw that it is 11 times lighter than the blood. So if you push the foam, it is very difficult, unless you put your needle inside the perforator, it is very difficult to push your foam inside the deep system. That document encouraged us. And we started to do foam sclerotherapy without ultrasound guidance, with all, and that is possible in government hospital only. So I will show you only one patient, the first patient that we successfully treated. And that is also the patient we are getting second hand. Means first the patient was treated in the Bangalore, and they did the rightly, they have done, flash ligation of the saphenofemoral junction and conservative treatment, but unfortunately he is a jute mill worker. He was I don't know where it is, no contract. So at that time he was a jute mill worker. They advised for a professional change, but it is not possible, see. Otherwise, it is good. I want to see one or two photographs of this patient. Foam sclerotherapy at first without ultrasound guidance, and let me go to the follow-up, first and second. And in every follow-up, as because of a big problem, big veins to deal with, lot of veins, so we added foam sclerotherapy, the rest of the part. So let's have the opportunity to see you. This is the first follow-up. So see, this part's improving. Already the operation has been done. The scar is not visible here. Here we have avoided these blowouts so that the foam doesn't enter into that. We're a little bit afraid to start with. So now see the posterior positions. Okay. And see the ulcer. It is started to heal. Okay. Still scars are there. Okay. Then what to do? Escape. And final. We have given third session of foam sclerotherapy. Before that, the photograph is that. See, the ulcer is nearly healed. The patient had got a great problem with the ulcer. See, this one, totally healed. So it works. It works. There is no doubt it works. Anyhow, I'm not going into detail of that. Now, let me go into not to show what we are doing, not to show anything else, don't take it that way, but to encourage the newer generation. As Professor Mahiti is here, invention, innovation, where you have got nothing, you can try anything. So we don't have any EVLT machine, we don't have any radio ablation machine, nothing. But what I have told, we will injure the intima of the vein by chemical injury we have tried, but thermal injury. So we needed a diathermy. But this is not the diathermy available in my college at that time. This is the diathermy I have downloaded. So we need a circuit. The original circuit I will show you. Why this circuit? This is a thermometer with an auto cut facility. Here I have got help from the Institute of Bioscience and Engineering, Jadavpur. Professor Tibrawal, he made this design. I don't have that idea about that. Anyhow, we need this catheter. What is that? Two electrodes in a plastic, like infant feeding tube, like catheter. Tip with a metal tip. And a small optical fiber so that it glows, so that we can study whether it is entered into the vein or not. Then we need a cover, just a cover. Then we need the electrode. First electrode touching that on the surface. Second, insulation. And third but not the least is a returned electrode. This we want. This we want. See, we can imagine. We can crudely design. But in this country, it is very difficult to develop. No one takes the interest. We need this magnetic cap so that we can manipulate, negotiate with a magnet. On the other hand, we want a glowing tip just for this catheter. We need insulation on that so that the heat doesn't come out. And we need electrode, then insulator, then another electrode. That much. We will make us for it. No one made it. So finally, what happened? We started to do with this. See, this is the diathermy. Can you imagine when we have started this? In NRS Medical College, we had this diathermy. You can't imagine that. Most of the rural hospital and even in government, nowadays it is improving. Nowadays we have, before retirement, I've worked for last 5 years with a valley level. But this was the diathermy. So, but bipolar was what? This is I have made this for the experiment. We have made it. See, can you concentrate on the tip? What is that tip? It is the infant radio tube with insulated copper. Yes, I made it raw at the tip. These are two at the insulated copper. Can you see that? Now, what I have done, we have done rather. So this is the connections, and in between there is that thermometer auto cut circuit, so that once the temperature raises, the generator stops automatically. And these are all you know for this central line. We have collected it, sterilized, and etc. We have used it. Even new was very difficult to get. Anyhow, now we need an ice pack for the local anesthesia, Prelocaine ointment, which was 75 rupees at the time, ounce meter, because I have to do a lot of calculations there. A calculator, and very importance of what should be the firing time. A little bit of mathematics. I square RT is equal to joule. Joule means heat, you know. You can remember this. The earlier age you learned it. That is watt into time is equal to joule. Here the joule is constant. And if you consider the time, the joule by watt. So this is the mathematics that we have to deduce there. So machine we said in the 20 watt, we need 80 joule. Time should not be exceed too much. Otherwise there will be dissipation of heat and skin burn. Or the nerve around that, the lower part. There is a possibility. So time is, what is that? 80 by 20 is equal to 4 seconds. But here is error, because it is a bipolar current and it is a coagulation current. So 40% of the time it will slip. So little bit time correction. 40 seconds it will slip in a second. So 1.6 seconds should be added with this mathematics. So total firing time we have to calculate manually. So we need a calculation staff, and it is a 5.6 seconds. So this is a thing. What is happening is before the operation. Name is there, date is there. See the result. But see, curves could not be negotiated with this raw catheter. We have combined this with the foam sclerotherapy, as Professor Mukherjee has done it. So there is another option, but we are giving a try. See the result. Not that bad. Not that bad. See the posture part. Not that bad. So what the message I want to do? Give it to this, my learned surgeons. See, here we are in the government institution. See, here is another patient. I don't want to see it. Here in the left part, that part is with the foam sclerotherapy, and this one we have tried but failed. But see the result. Foam sclerotherapy has a little bit of that. Anyhow, let's escape that. So this is the thing. So finally I want to convey this message in the government setup, in the medical college, where it would be a place where this sort of development should come, and the young generation of the surgeons, they will develop the utmost and the recent advancement in the venous surgery. It's a burning problem, and it doesn't cure at least. Once you treat a patient, if you don't, the patient misses. Dr. Mukherjee has already told you, if they misses the follow-up, the patient will come with a recurrence. So we are unfortunate. We have to do it in that way. And I will expect that diathermy, it is very cheaper for our country. We can handle it. Everyone is available. Only that catheter can be simplified. If it can be developed, then you learn a surgeon can try it. But the calculation, that can be automatized with a solid state computerized chip, IC. That is easy. The engineers are there who can make it for you. Thank you very much. Thanks a lot.
Thank you, Professor.